Uh, Good evening, one and all. Now, what I am trying to do is to recapitulate what we have done. I cannot reproduce the entire scanning. So let us actually, in a freestyle, we are going to flow through from top to bottom. So first, let me scan the brachial plexus, then the lower limb, the femoral on the anterior compartment. Then the third session will be the sciatic nerve. Then the fourth, again I will come back to the front, like pectoral trunk blocks, pec 1, pec 2, and then serratus anterior, abdominal blocks. And then the last session will be thoracic paravertebral, intercostal, quadratus lumborum and lumbar plexus. So I hope all of you would have been seen in the individual stations. There are different ways of doing a particular thing. This is one of the way that you can see and enjoy the process. With me, Dr. Shajish is there to show you the structures on the screen. If you have any doubt, you can interpret me in between. So let me start with the brachial plexus. I have a Sonosite H2 as an equipment with me. I am using a high frequency linear probe which has a capability of firing from 6 to 13 megahertz. So now what I will see is, I will start from the midline to the lateral so that we will know the known structures. So first I will keep my probe on the midline where you can see the isthmus of the thyroid gland on the topmost, and then the thyroid cartilage as an hypoechoic surface, and then a white crisp line which is the air inside the trachea. So below that we will not see anything because it is a replication artifact. So here in this picture you will see the isthmus of the thyroid cartilage as an hypoechoic band, and then the white line is the air inside the trachea. From there I am just sliding my probe towards the lateral side. Now you can see the strapped muscles which is just anterior to the thyroid gland, and you can start seeing the sternocleidomastoid muscle on top. So now as we know that when we move laterally, we will see the blood vessels, the internal jugular vein and the carotid artery. How we will differentiate the artery and venous? The artery is round, pulsatile, non-compressible, whereas vein is irregular in shape, it is compressible and non-pulsatile. Whereas artery is round, pulsatile, non-compressible. So when we move even more lateral, the sternocleidomastoid muscle ends. And just below that, you can see the anterior scalene muscle and then the middle scalene muscle. At this level, the muscles are not well developed. As I just scan down a little bit, the muscles will become much thicker. Reduce the depth. So in the resolution mode, reduce the gain. Little bit more. So see that image and change. See there. Okay. So now, there you can see the small round circles. Saji sir, can you? Yeah. So that is the nerve roots. Nerve roots are small hypoechoic round circle with a hyperechoic white margins. The nerve looks like a hypoechoic structures because they are predominantly fat, whereas connective tissues look hyperechoic. When I scan up, you can see these nerve roots are disappearing in a U-shaped structure. These are all bifid transverse process. So now what you are seeing is the C6 nerve root that pops up the transverse process. That is the C6 nerve root. As I scan down, you can see the next nerve root is coming out. Moment it comes out, it will become a multifascicular. So that is another nerve root. As I come down, you can see all the nerve roots are aligned between the anterior scalene on the medial side, middle scalene on the lateral side, and the transverse process, what you are seeing is a C7 transverse process. When you are seeing a C7 transverse process, you can see a pulsatile structure just close to the nerve roots. That is the vertebral artery. So if you look at the gap between the C7 root and the vertebral artery is very close. So if you are not very careful enough, you can inject even 2-3 ml into the vertebral artery, it will straight away deliver into the cerebellum and you will land up with complications. This is how in interscalene groove, even with the smallest local anesthetic volume, the systemic local anesthetic toxicity can be produced. So keeping these structure into the middle, if I just slowly drop the probe into the supraclavicular area, you will see the subclavian artery, round pulsatile, and then the brachial plexus, entire component will be organized superior and lateral to the subclavian artery. So this is the supraclavicular area. So only in supraclavicular area we can get the C8 and T1, whereas in interscalene groove you will see only C5, C6, C7. So if you want to anesthetize the inferior trunk, C8 and T1, you have to target the supraclavicular area. So now this is the brachial plexus above the clavicle. You can see the rib just below the artery and the post-acoustic shadow, and you can see the pleural sliding there. This is the brachial plexus above the clavicle, and we wanted to see the brachial plexus below the clavicle. So now what I am going to do is, I am going to put the probe onto the clavicle. Once you put a probe onto the clavicle, you will not see anything down because bone will reflect all the ultrasound waves and you will have only post-acoustic shadow. If I just drop my probe just below the clavicle and insinuate underneath, what you can see is again pulsatile. We will call this as an axillary artery. Now this is the, I orient myself better, increase the depth a little bit more. One step more. Yeah. No, reduce the depth. Yeah. Now the first topmost muscle is the subclavius muscle, and then below that is the brachial plexus elements are entirely grouped just lateral to the axillary artery. So all the brachial plexus elements are just grouped just lateral to the first part of the axillary artery. This is the costoclavicular space. Can I have the pointer, Shaji? Freeze panama. So now in the costoclavicular space, if you look at, this is the pectoralis major muscle and this is the subclavius muscle and this is the serratus anterior. Between these two muscles, the entire brachial plexus elements, this is the cord. So I will put my probe at this level. This is the cords. It will be lateral cord, medial cord, and then the posterior cord. Everything will be grouped in a compact manner, sandwiched between the subclavius muscle and the serratus anterior. This is the second rib with the post-acoustic shadow, and this is the pleura. This is the first plot of the axillary artery. So in this place, if you deposit the drug in one point, the chance of blocking all the elements are much higher. And in this space, if you insert a catheter, the catheter will be more stable and the chance of blocking all the elements are much higher again. So this is a costoclavicular space. The space between the subclavius muscle and the serratus anterior, all the cords are sandwiched, just lateral to the axillary artery. Unfreeze. Shaji sir. So now from there, if I just scan the brachial plexus element just laterally, you will see all these, the nerves will wind around. Now you can see the axillary artery pulsating and you can see the neural elements are distributed. Even now you can see one is on the medial side and you can see the nerve roots are migrating towards the posterior. The posterior cord going behind, and as I go more and more lateral, now you can see clearly the three cords. One is the lateral, the medial, and then the posterior. When I go scan, the cord will completely wind around the axillary artery. This is the lateral infraclavicular block. The topmost muscle is the pectoralis major, and the muscle below is a pec minor, and below that you will see the blood vessels and all the three cords winding around the axillary artery. At this place, can you freeze? So the difference between the lateral infraclavicular and the costoclavicular is, if you look at in this place, this is not working. Intermittent. So the difference between the costoclavicular space and the lateral infraclavicular is, here you can see the cords are divided. This is one cord and this is one cord, this is one cord. They are all spreaded around a wider area. Whereas if you look at in costoclavicular space, all the three cords are compactly arranged in a small facial compartment. So that is the difference between costoclavicular space and lateral infraclavicular space. In this, if you wanted to block, you have to use a multiple injection so that the chance of blocking all the elements in 30 minutes is much higher. Whereas in costoclavicular block, in one single point, you can access all the components. Jelly. Now from there, if you just drop the probe to the axillary unfreeze, so all the brachial plexus elements are completely winded around. I am going back to the costoclavicular space. You can see all the cords are moving and then going compactly arranged just lateral to the axillary artery in the costoclavicular space. When I come down, you can see the cords are getting separated and then winding around the axillary artery here. So similarly, when you drop to the axillary area, now you can see the axillary artery, axillary vein on top, and then the conjoint tendon. The sharp white line beneath is the conjoint tendon. And then you can see the neural elements. Reduce the depth. The neural elements, that is a median nerve, and then the radial nerve will be just behind the artery, and then the ulnar nerve between the artery and the vein. And then the musculocutaneous, sometimes you can see it here because it is originating at very later. So in these patients you can block it here itself. So it is not given up even at the much lower level also you are not able to identify. So if you block it at this level itself, the musculocutaneous nerve will get blocked. Can you freeze it? Yeah. So now, in the axillary area, this is the median nerve group, and this is the ulnar nerve group, and this is the radial nerve, and this is the conjoint tendon. You will see the musculocutaneous nerve between the biceps and the coracobrachialis. Sometimes if you are not able to see, that means it is well within the median nerve itself. So if you block all these three components, that is the axillary block. So now we will go to the lower limb. Is there any doubts that I can answer? Slow. Something is gone.
Cable conduct. Cable conduct.
So now, in terms of brachial plexus, the advance is, yes, madam.
At times the medial cutaneous nerve of arm gets scathed when you are trying to do these blocks.
Yeah,
and
now.
Especially for the supracondylar humerus and all. So can you just say how to take care of that?
Yeah. That is not the medial cutaneous nerve of arm, that is the intercostobrachial nerve. Yes, the medial cutaneous nerve of arm supplies this. It has got an interaction with the intercostobrachial nerve as well. The medial cutaneous nerve of arm sometimes get communication from the intercostobrachial nerve, which is a branch from the second intercostal nerve. So you cannot block through the brachial plexus. That intercostobrachial nerve can sometimes extend variably on the posterior aspect. So in which individual that will go extensive on the posterior aspect, you may not know. So especially from the posterior axis, either it is humerus or a supracondylar humerus, you have to have a separate skin infiltration to take care of the intercostobrachial. It is not a medial cutaneous nerve of arm, because medial cutaneous nerve of arm you will block with the brachial plexus. It is only the intercostobrachial and its interaction with the medial cutaneous nerve of arm is what creates the problem. Right now there is no consistent way to block the intercostobrachial. Even separately we have done a paravertebral injections at T2. Still in some patients we are getting sparing. So when we look into the literature, this intercostobrachial takes connection from third, fourth intercostal nerve as well. So it is not just arising from one intercostal nerve, it has got communication from 2, 3, 4. So it is really a big challenge to block the intercostobrachial. There are various techniques has been tried, like PEC2 also will block the intercostobrachial with the varying results. So we have to look at lot studies to look at whether we can block consistently intercostobrachial. Sir?
Sorry, Shiva. Sorry to interrupt. Yeah, that's what I want to come to say, because PEC2 sometimes takes intercostal
Yes.
and when they dissect, the surgeons open up the plane and you get the thoracodorsal as well as the intercostal block nicely sometimes.
Yeah.
But specifically going, there's nothing.
So now coming to the lower limb. Come that side. So femoral nerve, have you all seen? Now the target of interest is we will first pick up the femoral artery. So now first we have to pick up the femoral artery and get that target onto the center. And the first thing is now you will see the femoral artery as two divided. So one is on top, one is below. So first thing is you have to scan above and make sure you have the single femoral artery. That's the first step. Now you have a single femoral artery. When you scan down, it has become two. Because the femoral nerve again will get divided into anterior and posterior branch when the artery also divided. So the first target is getting a single femoral artery is your first aim. And then you look at laterally for the femoral nerve. Can you reduce the depth? If you look at us, the hypoechoic structures just lateral to the femoral artery is the femoral nerve. Sometimes if you are not able to see it very clearly, if you deposit the local anesthetic below the fascia iliaca, that will create a contrasting environment. The local anesthetic will be on top and the nerve will be clearly depressed down. That is how we will confirm that it is a femoral nerve. So now, if you trace the femoral nerve down, the adductor canal is the place where you can give the terminal branch of the femoral nerve. Increase the depth. So that is the sartorius muscle. Again, the target is your femoral artery. So once you see the femoral artery, you can see at the corner, the topmost corner is the saphenous nerve, that is the terminal branch of the femoral nerve. Below the sartorius muscle, your target is femoral artery and the vein, and then you can, this is the saphenous nerve block, a saphenous nerve which can be blocked under the sartorius muscle at the adductor canal. You can go as much down as much possible so that the local anesthetic will not spread above and produce quadriceps weakness. So that is the benefit of adductor canal block. Without producing a weakness of the quadriceps, still you will anesthetize, provide analgesia to the knee surgeries. So this is the adductor canal block, femoral artery, vein, and this is the honeycomb pattern of saphenous nerve. So now if you go down for ankle procedures, your aim is to only pick up the saphenous vein at the foot. So reduce the depth. You can see the saphenous vein on the topmost. So here you have to just identify the vein and then deposit the local anesthetic around it. You need not look for the saphenous branch because it is a very thin nerve. It will goes along the great saphenous vein. If you are not able to see the vein, you can apply a tourniquet and then recruit the saphenous vein and deposit the local anesthetic around it so that your medial side of the leg will get anesthetized. So this is the front side of the foot. Then we will go to the sciatic nerve. So now in the sciatic nerve we can access the sciatic nerve from the high frequency probe cart. In the sciatic nerve, we can pick up the nerve from the very origin, increase the depth. And I have the deeper probe. So we can trace the sciatic nerve from the greater sciatic foramen to the individual nerve branches. Now first we will see the parasacral approach to the sciatic nerve. What I am going to do is I am going to slide my probe. I am took a low frequency probe because my target is goes more than 4 centimeter deep, reduce the depth. So now I am getting a continuous ilial bone on top. So the bone is a continuous one here. Increase the gain. So this is a continuous ilial bone. When I scan down, you will get a break in the continuity of the ilial bone, and if you insinuate, increase the. Can I update? Or can you just lie down like this? இந்த பக்கம் திரும்பிக்கும் அந்த கால் அப்படியே காலை லேசம் மடக்கிக்கும் சொல்லி. Now I am just taking the greater trochanter and then the posterior superior iliac spine. I will put my probe in the proximal 1/3. Now you are seeing a continuous ilial bone. So now as I scan down parallel to the, freeze it. Can you have the image? Yeah. So now this is the ilial bone which has got broken. One half is here, one half is here, and this dark muscle is the piriformis muscle, and this is the sciatic nerve. So now I will scan you again, show you. There is a gap between the continuity of the ilial bone. This is nothing but a greater sciatic foramen. And then once you get the greater sciatic notch, you can see the piriformis muscle running from medial to the lateral. It is a dark band muscle. And just below that you can see the sciatic nerve with a vessel inside. So now I will again repeat my scan so that you can better appreciate. So now first thing is from the posterior superior iliac spine and the greater trochanter, make a line and take in the proximal 1/3, put your probe and see a continuous ilial bone. And I am slowly sliding my probe down. Now it is getting broken. Going up, it is a continuous ilial bone. I am just parallelly shifting down, it has become broken. And now you will see a dark band on top, that is a piriformis muscle. Below that, the hyperechoic structure is the sciatic nerve at the exit at the greater sciatic foramen. This is a parasacral approach because at this place if you deposit the local anesthetic, then only it can go into the sacral plexus. It will anesthetize your hip joint. If you want to provide analgesia for hip joint, this is the block that we have to be doing, not anything distal to that. So after this we can come to the subgluteal approach, where on one side we have to see the greater trochanter, on the other side we will see the ischial tuberosity. So now I am just keeping my probe. If I move lateral, that is a reduce the depth. Okay. You are seeing a 2 bony humps. So this is 1 minute, can you freeze? Okay. So now, yes, this is one bony hump. This is nothing but an ischial tuberosity. That is the greater trochanter, and that is a quadriceps. And this is hyperechoic structure is the sciatic nerve, which is sandwiched between the 2 muscles, the gluteus maximus and then the quadriceps, and then the quadratus femoris. Between the 2 muscles, this nerve is sandwiched. This is a ischial tuberosity, again a bony landmark with a clear-cut hyperechoic line and shadow. This is a greater trochanter, clear-cut hyperechoic line and shadow. Between the 2, you are seeing a 2 muscle groups, gluteus maximus and quadratus then in between the two you are seeing an hyperechoic structure. This is subgluteal approach to the sciatic nerve. If you want to provide anesthesia to the thigh and knee, we will access the sciatic nerve at this level. Then as we go down, just use this and then. So now we can increase the depth. The sciatic nerve is on top. That is the superficial, that is the sciatic nerve. You can trace all the way down. Since now the sciatic nerve has become superficial most structure within 4 centimeter, I will use my high frequency probe so that you can see the difference in the clarity. கொஞ்சம் பக்கத்துல கொண்டு வந்துறியா? So now I am scanning from the mid thigh. Probe எடுத்து கேட்டேன். The probe எடுத்து. Increase the depth. So now in the mid thigh from down, I am just scanning down. Now you can see the sciatic nerve at the center of the screen. You can trace it all the way down. Now starting from the subgluteal region, I will scan all the way down. You can see the target structure onto the middle, and then I am going down to the from that side. So sciatic nerve on the center of the screen, I am just scanning it all the way down to see where it is getting bifurcated. Now still it is onto the center. Now you can see that it is slowly dividing into two. So in this patient, the femoral, the popliteal vessels are much lateral. You can see the popliteal vessels are here. You can see the vein that is getting compressed and the artery is pulsatile. Whereas if you look at the sciatic nerve is situated much lateral to it. So these are all the anomalies that you can pick up. As I go down, now only it is getting separated into tibial and then common peroneal. I will go down, you can see the common peroneal is moving to the probe marker. When I go up, it is coming and joining the sciatic nerve and it has become a single nerve. I will go down, now it is getting separated tibial and then common peroneal. You can trace the common peroneal alone, it will go in and then winding around the tibial head. The sharp white line below is a fibula head. And then while I am coming up, this nerve is moving back and then joining the tibial nerve. So now it is a single nerve. When I scan back, it is dividing into common peroneal and then the posterior tibial. Now it is a two different nerves. So now this is the common peroneal and posterior tibial. If we wanted to scan the other individual nerves, if you even wanted to scan down, reduce the depth. So this is the posterior tibial nerve, that is a posterior tibial artery. Just behind it, the honeycomb pattern is a posterior tibial nerve. The tibial nerve is going to continue as a posterior tibial nerve. The common peroneal nerve divided into an anterior tibial and superficial peroneal. So here the landmark is posterior tibial artery is a landmark for posterior tibial nerve. Now for the sural now, it is the short saphenous vein. Can I just take it? Now if you look at the hypoechoic structures on the lateralmost side, the small one, that is a short saphenous vein. So just this side. Yeah, so that is the, just behind that target is the sural now, which situated just superior lateral to the short saphenous vein. This is a one nerve, and then anteriorly when you go, முன்னாடி படிக்கிறியா கண்ணா நேரா திரும்பிக்கோ கேபிள் மாட்டுது கேபிள் For the anterior tibial nerve, the target is only the tibial artery. Reduce the depth completely. Now you can see the anterior tibial artery that is pulsating. You trace it a little bit back. If you deposit your local close to that, you can see at the 3 o'clock position, at the floor, that you can see the honeycomb pattern. If you deposit your local there, you will block the anterior tibial nerve. So we have seen posterior tibial nerve, anterior tibial nerve, and then the sural nerve. Saphenous vein you will block along the great saphenous vein. If you see and block, that is more than enough. If it is collapsed, then you can apply a tourniquet and do it. Then one more nerve is the superficial peroneal nerve. That will be lying between the muscles. So you will be able to pick up the peroneus longus brevis, and then the two group of muscles are joining, and then on top the honeycomb pattern between the two muscles. Can you freeze it? Yes. So now between the two muscle group at the joining, this honeycomb pattern is the superficial peroneal nerve. So only for superficial peroneal nerve the landmark is a muscle group, whereas for all the other nerves like anterior tibial nerve, the landmark is anterior tibial artery or dorsalis pedis artery. For the posterior tibial nerve, it is a posterior tibial artery. For sural nerve, it is a short saphenous vein. Saphenous nerve, it is a saphenous vein again. So only for the superficial peroneal nerve, these are all the peroneal muscles. On the joining area, you can see the honeycomb pattern. So you can individually look at all the 5 nerves and you can block for ankle block. Or you can go above, where it divides into tibial and common peroneal, you can block there as well. So this is the sciatic nerve. Now we will go to the pec 1, pec 2. So now coming to the trunk. Any doubts that I can answer? So if you look at the point is, I will always try to look at the reference point, not the nerves, because these are all very small structures which you cannot track all the time. So always I try to relate the nerves to the reference points, either artery or the bone. Only the superficial peroneal nerve lies between the two muscles. Coming to the trunk blocks, we will see the pectoralis, pec 1, pec 2, and then the sap. Then we will go into the abdomen, rectus sheath, and the tap.
Okay.
Jelly. Unfreeze. Unfreeze it. Increase the depth. So now I am just keeping my probe just below the clavicle, cutting the pectoralis major and minor in a perpendicular manner. So now, one minute, don't freeze. See, now you are seeing the two muscle planes Freeze it. So the one on top, this is the pectoralis major and this is the pectoralis minor and this is the plane and this is the neurovascular bundle. These are all the pectoral nerves. So if you deposit the local anesthetic between the pec major and the pec minor, you will anesthetize the pectoral nerves. And the pec 1 is between major and minor, whereas pec 2 between pectoralis minor and the serratus anterior. I will show you and screen it. So now I am just scanning a little a bit and then making a slightest medial inclination. Freeze it. Now here you are seeing the three muscles. The one on top is a pec major and this is the pec minor and this is the serratus anterior. So the local between these two planes, between major and minor is a pec 1, between minor and serratus, and this plane is a pec 2. So because these pectoral nerves travel in this plane and then come back to this, it requires both the planes to be blocked for that an effective block. Because these pectoral nerves are not individual nerves, they literally form a plexus under the pectoral muscles. So you need a more volume at that plane so that you can effectively block the pectoral plexus. It is not pectoral nerves. So this is pec 1 and pec 2. Similarly for serratus anterior, the serratus anterior bulk is formed between second and fifth intercostal muscles. Unfreeze it. So now I am just going back so that I will pick up the latissimus dorsi. Can you freeze it? Unfreeze. Yeah. Please. So now if you deposit the latissimus dorsi, the topmost muscle, and this is the serratus anterior, if you split up this plane, then the local anesthetic will spread between the serratus anterior and latissimus dorsi behind. That is a serratus anterior plane block. In these planes, we are not targeting the individual nerves, we are targeting the plane so that the nerves that travels in this area will be blocked by diffusion. So these blocks are otherwise known as diffusion blocks. So now coming to the abdomen, where we will have the center is the linea alba, and then when I come just lateral, you can see the rectus muscle. Freeze it. So now, if you just, this is the posterior rectus sheath. Here actually there is a two layers that you are seeing. The first white line is the rectus sheath. If you separate the rectus muscle from the rectus sheath, that is called rectus sheath block. So for the T6 to T10, for upper abdominal incisions, you have to block the rectus sheath block. And then for the T10, from umbilicus to below T12, we will do a classical tap. Unfreeze. The tap block is we have to identify all the three muscles of the abdominal wall. I'll come, freeze it. So now you are seeing three muscles. One is the external oblique, internal oblique, transverse abdominis, and this is the peritoneum and peritoneal cavity. From down it is transverse abdominis, internal oblique and external oblique. The thickest muscle is the internal oblique, and the plane between the internal oblique and the transverse abdominis, this is the plane of tap plane. So that where if you put a 15 to 20 ml of local, you can block the T10, T11, T12 nerves. So that is for the tap. So now we will go to the back. Shirt creating. Shirt creating. Kalana Bokantonga Botuko. Show you the thoracic epidural, paravertebral, and then intercostal. See, now since he is a thin boy, let me see with the high frequency probe whether I will get a good clarity image. So I am going to keep my probe a paramedian sagittal view, increase the depth. First I will come from the lateral side. Yeah. So these individuals are the transverse process, increase the gain, far gain, go to the penetration mode. When I come to the midline, reduce the depth, increase the depth. கை ஊனதுக்கண்ணா கை ரெண்டுத்தையும் முட்டி மேலே வச்சுக்கோ. Reduce the depth. Increase the depth. Increase the far gain. Increase it. So this is not very clear, but you can appreciate two things. Screen has gone. Okay. So now if you see, this is a crisp white line with the dense acoustic shadow, and there is another crisp white line. These are all nothing but a lamina of the thoracic vertebra. This is, so for the paravertebral I am using a transverse scan. So first in the midline, 1 minute, freeze. So first let me identify the bony landmarks. This is the spinous process, this is the lamina, this is the transverse process. So I am cutting the vertebra in a transverse view, spinous process, lamina, and then the transverse process. This is otherwise known as a tower sign. So once I come laterally, you will see the paravertebral space. Unfreeze it. So spinous process, transverse process, and then you can see that is the rib, which is, freeze it. So now this is the lamina and this is the transverse process, and rib is articulating with the transverse process. Since these are all our bony structures, you are not seeing anything down. Dense post-acoustic shadow. So from this point, if I slide my probe or tilt my probe, I will drop between the intercostal space and I can see the paravertebral space. Unfreeze. So now again I am coming from the midline. You can see the spinous process, transverse process, and then the rib interacting with it, and then I slightly drop. So now you can see the pleura which is sliding, and the pleura is going and disappearing under the, see that image and correct us. So freeze it. So now, yes, that is the paravertebral space. This is the facet joint level. Here you are not seeing the transverse process. Pleura is disappearing, and that is a costotransverse ligament. And this wedge-shaped space is the paravertebral space. So this is the pleura, this is the ligament, and then this is the facet joint, and this space, this is the base of the triangle, this is the apex of the triangle, and this is the paravertebral space. So now if you go little more laterally, you will cut the ribs. Unfreeze. These are all the ribs. What you are seeing is a hyperechoic line with a dark shadow. Freeze it. So this is the cephalad, this is the head end, this is the foot end. So this is the lower part of the rib. So you can hit the rib and then walk off so that you will get the neurovascular bundle at this. If you can clearly watch, this hypoechoic circle is nothing but a intercostal artery, and this is the area where the neurovascular bundle lies. And that is how we will give the intercostal blocks. Now, any other, what we left is lumbar plexus and then the quadratus lumborum. படுத்துக்கண்ணா படுத்துக்கோ அப்படியே படுத்துக்கோ ஒரு கிழிச்சு கை எப்படி வச்சு அதை விட்டுரு யாருன்னா கயிறு எடுக்கணுமே. So So now for the quadratus lumborum, what I am going to do is I am going to trace the abdominal muscles posteriorly and then see where they are going to end and how they are going to interact with the quadratus lumborum muscle. So I am putting my probe in front. So now you are seeing all the three muscles together, external oblique, internal oblique, and then the transverse abdominis. I am slowly tracing the muscles back. I am going back. The external oblique is ends, internal oblique continuous. Below the transverse abdominis is there. I am going back. Now you see the muscle in front. Increase the depth. I have the low frequency probe. So now since my target of interest is going deep, I am choosing a low frequency probe. Reduce the depth. So now you are seeing all the three muscles together, which is superficial, which may not be very clearly visible in a deeper probe, but we will see the deeper structures here. Can you get a stool? Increase the depth a little bit more. Now can you freeze it? I have this. So now if you look at, this is the quadratus lumborum muscle, and you can see the peritoneal movements here. When I will scan you back and then show you, this is the vertebral body and this is the psoas muscle, and this muscle is the quadratus lumborum muscle. And when I doing a real-time scanning, you can see the movements here, and then you can differentiate a static muscle and then the moving retroperitoneal structures. Unfreeze. Reduce the depth. So now you can see the peritoneal structures are moving. Just above it, the flat dark muscle with a hyperechoic line is a quadratus lumborum. When you go even more proximally, increase the depth. So this is the transverse process, and this is the, can you freeze it? Sorry. Now if you look at this image, this is the just shot of the transverse process, and this is the psoas muscle, and this is the fascia of the psoas muscle, and this is the quadratus lumborum muscle, and this is the anterior anterolateral surface of the vertebral body. This entire muscle is the psoas muscle, and this is the quadratus lumborum muscle, and this is the fascia of the quadratus lumborum, whereas this is the fascia of the psoas muscle. You have to deposit the drug between the two. So that is the quadratus lumborum block that will block. If you deposit at that level, this facial compartment communicates into the thorax as well. You may get an extension from T4 to T12. So this is the quadratus lumborum muscle, and this is the psoas muscle. And even lumbar plexus, this is the psoas muscle. We will target between the posterior 1/3 and anterior 2/3 if you use a nerve stimulator and locate the twitch and then inject the local anesthetic here. So this is a lumbar plexus. So even if you miss your needle from the quadratus lumborum into the psoas, it will become a lumbar plexus block. So you will produce a complication. So that if you use a specific nerve stimulator and stimulate and identify, you can precisely give a lumbar plexus block. So these are all the posterior blocks. So with that, I hope we have covered all the blocks that you have seen today. Any doubts that I can answer?
Dr.
Yes, sir.
Sivashanmugam. I was a faculty in Station 10 along with Dr. Mardhachalam. Just one point of clarification, because I have been teaching all these delegates that bone is black. And the purpose of that was when we were doing a PEC 1 and PEC 2 block, I wanted them to see the two pillars. And I just want to clarify the reason for that was the post-acoustic shadow is what I was describing as black. So don't get confused between, because somebody said the bone is white, somebody said bone is black. But the whole important thing is the post-acoustic shadow, which the bone creates anywhere in the body.
Hey, mic off. Color mic off.